Hello, good morning, good afternoon, depending on where you are joining us from. On behalf of the President, I want to welcome you to our October 2022 meeting. And I can see Dr. Jenny Fuja online. Welcome, sir. Professor Grange from the US, welcome, ma. I see a few new faces. Adamu Rabasa, my good friend from Maiduguri, welcome. Today, we have, like I said last month, a very young, dynamic, young pediatrician who is going to make a presentation to us. I can see she's nodding her head. And also the moderator for today is Dr. Olufunmilayo Adeniyi. And in our usual tradition, I'll hand over to the President to say a few words before we proceed. Over to you, sir. Dr. Mobolaji Lawal. Dr. Mobolaji Lawal, are you still online, sir? I don't think Dr. Mobolaji Lawal is online. He will join us later on. He was online a few minutes ago. So I'll hand over to the moderator for today to briefly introduce our speaker. Over to you, Dr. Adeniyi.
Okay. Thank you very much, sir. Good afternoon, good morning, good evening to every one of us, wherever we are in the part of the world. We are most welcome. I'd like to thank all our elders in the house. Dr. Jenny Fuja, Professor Grange, Dr. Mobolaji Lawal, Dr. Iletu, and many of all our other elders in the house. All our pediatric practitioners located everywhere in the world, we are most welcome. This afternoon, we are going to be discussing a very important topic, important to pediatricians and important to even the mothers, especially young mothers who don't have a lot of experience in taking care of children. We are going to be talking about infantile colic, which we know is a behavioral problem in infants that make them to have a lot of inconsolable crying episodes. Our speaker today is a well-seasoned pediatrician. She has a lot of wealth of experience in managing patients with infantile colic. I would like to introduce our speaker for today, Dr. MARIYA MUKHTAR-YOLA. She graduated from the University of Maiduguri with a distinction in pediatrics and microbiology and was the overall graduating medical student of the session at that time. Thereafter, she undertook her postgraduate studies at the Lagos University Teaching Hospital. She is a fellow of both the National Postgraduate Medical College of Nigeria and the West African College of Physicians. She also holds a master's degree in public health from the University of Sheffield, England, and she graduated with a merit. Her special interests include neonatology, pediatric infectious diseases, for which she trained at the Cincinnati Children's Hospital in Ohio, USA, and the Children's Hospital's Jesup wings. She has also had several trainings at the Institute of Human Virology in Baltimore, USA, and she has additional certifications from London School of Hygiene and Tropical Medicine, University of Liverpool, as well as University of Washington. She currently works as the Chief Consultant Pediatrician / Neonatologist at the National Hospital, Abuja, where she serves as the head of the Neonatal unit. She has published in both local and international peer-reviewed journals, books, and she has also participated actively in the development of several national guidelines and technical reports. She has served in various management and leadership positions, editorial boards of several journals, and that of Faculty of Pediatrics. She has received several awards for meritorious service to children and for leadership, including those from the Kano State government in 2010. Dr. Mukhtar is an active member of the Pediatric Association of Nigeria, the Vice President of the Nigerian Society of Neonatal Medicine, and a member of the Nigerian Society of Pediatric Infectious Disease. She's an examiner at both National and West African College of Physicians as a child health specialist. I would like to welcome humbly Dr. MARIYA MUKHTAR-YOLA, a seasoned pediatrician and neonatologist, to share with us infantile. You're welcome, Dr. MARIYA, with us. Our president.
Thank you, Dr. Adeni. Just before Dr. Mukhtar will speak, Dr. Mobolaji Lawal is back on. Can you say a few words, sir, before we start, sir?
I think you should just continue. I'll say something at the end.
Okay,
Sorry about that. I lost connection temporarily here. So please, just continue with the program. Yeah.
That's fine, sir. So, MARIYA, the ball is in your court.
Yes. A very good afternoon to Baba and Mama. They know who they are. Our elders, our teachers, my senior colleagues, my colleagues and students. Indeed, it is a very great pleasure to be communicating this afternoon on a topic that everyone has had an exposure and experience with, but not everyone knows what to do with it, even after you have presumably treated the child. So it's still a dilemma, and it's a very vibrant topic any day, infantile colic. I want to especially thank the Guild of Pediatricians in Private Practice for inviting me to this platform to deliver this topic. Victor, can I share my slides, please?
Yes, go ahead, ma'am.
All right, thank you. Oops. All right, so we'll be talking about infantile colic, and many of us on this platform are mothers, fathers, grandmothers, grandparents, and I'm sure every one of us, or almost everyone, would have one story or the other to share about this topic because of how much of a problem it is to pediatricians. Okay, so this will be the outline of my presentation, and I'll begin with a case presentation. Mrs. A presented to the clinic looking exhausted, sleepy, and unkempt. The father is away on a business trip. She complained that her 3-week-old baby suddenly starts crying inconsolably at the top of her voice. Most evenings for several hours in the last 2 weeks. As it is common in Africa, the neighbors have been calling and have offered at least 10 regimens to help, but all to no avail. The baby is feeding normally in between and has been gaining weight, as evidenced at the last clinic visit, and there were no other complaints. You are the healthcare personnel on duty. What do you think is happening? And how would you help this family? And how many Mrs. A's are here amidst us? I'm sure there are many of us. I, for one, was one. I remember very clearly when my second son, at about the age of 4 weeks, just started acting abnormally, crying at 5 p.m. on the dot, as if he had an alarm clock inside him. He would cry and cry and cry and cry nonstop. I was a pediatrician in training, but I couldn't do much. I would carry him and run to the neighbor who was a nurse. My neighbor was a nurse. Would toss him around, would juggle him, would feed him, would do whatever, would give him whatever medication we give. He just wouldn't stop until it was time to stop. In the end, both myself and the neighbor would probably end up crying without much success. And I'm sure there were many young mothers like this that it has happened to. So it's still a very difficult thing. Having a baby with colic can be very upsetting and exhausting. For many parents, can easily feel helpless in supporting their baby. And believe you me, when your baby has colic, you will cry soon because you end up not knowing what to do. So how is colic defined? It is defined clinically as repeated episodes of excessive and inconsolable crying in an infant that otherwise appears to be healthy and thriving. However, there are several research definitions for consistency. Initially, it was defined as paroxysms of irritability, fussing, or crying, lasting for a total of 3 hours in a day and occurring on more than 3 days in any 1 week period of 3 weeks in an infant who is otherwise healthy and well-fed. Otherwise, it's the rule of 3. 3 hours a day, occurring more than 3 days in any week, for a period of 3 weeks. That was the classic research definition by Wessel et al. In 1954. However, this was modified by Hyman et al. In 2006, and it read that it could be defined as modified as episodes of irritability, fussing, or crying that begin and end for no apparent reason and last at least 3 hours a day, and at least 3 days a week for at least 1 week in an infant up to 4 months of age with no evidence of faltering growth, which means the child is growing well. So what is the cause of infantile colic? Nobody knows. The exact underlying cause of infantile colic is not known. It may, however, reflect part of the normal distribution of infant crying, according to Acnic in 2014 and Lucasen and Walker. However, there are several other possible causes, which may include abnormal gastrointestinal motility and pain signals from sensitized pathways in the gut viscera, inadequate amounts of lactobacilli and increased amounts of coliform bacteria in the intestinal microflora, which actually influence gut motor function and gas production. It could also be due to psychosocial factors such as family tension, parental anxiety, inadequate parent-infant interaction, or even overstimulation of the infant, or it could be a misinterpreted cry. Now, how common is infantile colic? This actually varies depending on the study type, the study population, and the definition of colic used. But the global prevalence is estimated to be as high as 20%. A meta-analysis of 28 diary studies involving about 8,690 infants reported prevalence of colic in the first week of life to be between 17 and 25%. And by 8 to 9 weeks of life, that comes down to about 11% and comes down to about 0.6% by 10 to 12 weeks of age. A review article reported that 1 in 6 families with children that have colic symptoms actually consult a healthcare professional. Colic usually occurs equally in both breastfed and formula-fed infants, and equally in both sexes and races, So it happens all over and to everyone. So how do they present, these babies? Typically, an infant with colic presents with excessive, inconsolable crying or fussing, which starts in the first weeks of life, but usually would resolve around 3 to 4 months of age. The crying most often occurs in the late afternoons or evenings. The baby tends to draw up his knees up to the abdomen and onto the abdomen and holds it there while crying. We need to get a lot of history in order to determine what actually is the cause of this colic in various babies. Important history to ask would be the onset, the duration, the frequency and timing of the crying episodes, the change in tone or pitch of the crying, presence or absence of any alleviating or exacerbating factors. It would be good to find out the gestational age, any history of birth trauma, any abnormalities congenitally, such as ankylosing, which might affect a feeding, cleft lip, cleft palate. The birth weight of the child is important. What has been the weight gain? Is the child gaining weight adequately, or is there faltering growth? And what is the general health behavior? We must also look for red flag symptoms, such as apneic episodes, cyanosis, respiratory distress, bile-stained or projectile vomiting, or blood in the stools. Other aspects of the history we must explore include history of reflux, constipation, or even the presence of a rash, which may suggest another underlying cause. We must establish the feeding pattern. What is the frequency, the duration? How many times does the child feed at night? Any feeding problems? What is the timing in between feeding and crying? What is the method of constituting formula feeds, if that is what is used? What is the winding technique or winding technique? We must ask about other fluids or foods given. When were they started? What is the quantity? What is the frequency? Is the baby on a dummy or a pacifier? What is the sleeping pattern? What is the routine for that child? There's so many things to ask. And amongst the family and social history, there also we need to know what is the parental response to crying, including coping strategies and the impact on parents and family, including siblings. Just yesterday on our platform, there's a shocking picture that was posted of a father who hit his baby with a hanger because the baby was crying inconsolably and the mother had stepped out. And I remember Professor Bringe's comment that the man needs mental health assessment, but he couldn't handle it. It is that degree of stress that infants with colic can put on parents. Though this man probably has mental health issues and he probably needs to be evaluated. So we must also ask about associated insomnia, stress, anxiety, depression, or postnatal depression. What are the beliefs or ideas, the concerns and expectations of the family about infant crying? Okay, what is the family support service that is available? Is there any history of allergy or atopy in the family or in other siblings? What is the smoking or alcohol history? What about the mother, her breast, any nipple pains, nipple shields? So we must explore everything that would affect breastfeeding. Does she use alcohol or caffeine, which might overstimulate the baby and make the child to cry more? Any complications during pregnancy? All these questions are very important in the evaluation of a child with colic. And when examining, we must examine the infant for suitability of the clothing. For the child may just be hot and uncomfortable or tight in a certain cloth. Okay, is there any fever, any features of dehydration? What is the weight? Are there skin rashes, any tongue tie, any candidal infection? Looking for anything that might make the child uncomfortable. any neurological anomaly, any signs of bruises, petechia, or trauma, which may suggest child maltreatment. We must also examine the mother, the nipples. Are they adequately everted? Are there any ulcers or wounds around the breast, which may cause breastfeeding problems? Apart from the mother, even the other carers around her, we need to ask about them. What is the level of interaction with the infant? How is that infant handled? Okay, so that we can understand the social aspect. Now, there are several differential diagnoses to consider for a child with sudden onset of crying. If it is sudden and recent, we must rule out a physical illness, such as intussusception or volvulus, corneal abrasions from nail scratches, a strangulated hernia, pyloric stenosis, sepsis, child abuse. These are all things that can present with excessive crying in an infant. If the symptoms, however, are more persistent, then we must rule out things like discomfort, as we said, either from hunger or dehydration due to breastfeeding problems, excessive heat or cold, tight clothing, constipation, excessive wind, and gastroesophageal reflux. Cow milk protein allergy or transient lactose intolerance is another cause of possible concern in a child that is restless. Indigestion problems. Infantile spasm can actually present in a weird manner. Okay, rarely there might be congenital or other metabolic issues. Let's talk briefly about cow milk protein allergy. Now, cow milk protein allergy can be classified according to the underlying immune mechanism, and immunoglobulin IgE-mediated food allergy produces immediate symptoms which may affect multiple organ systems, typically 2 hours after ingestion of cow milk. So for children that are fed on formula milk, we need to explore, could they be reacting to the milk? Okay, cow milk allergy is one of the most common presentations of food allergy seen in early childhood. Almost all cases present before the age of 1 year. A diagnosis of IgE-mediated allergy should be suspected, particularly if symptoms are multiple, persistent, severe, or treatment-resistant. Typical symptoms include urticaria, angioedema, itching, cough, hoarseness, wheezing, or breathlessness after cow milk ingestion. A diagnosis of non-IgE-mediated allergy should also be suspected if there are 1 or more symptoms, such as gastroesophageal reflux disease, abdominal discomfort, constipation, diarrhea, or atopic eczema, particularly if the symptoms are treatment resistant. Now, in Nigeria, we have a lot of local myth about colics and bus. You know, the neighbors would tell you a lot. The grandma would say a lot. Everybody has a different definition for what colic means. For some people, colic means pain. For some, it's just a crying baby. For some, it's normal and it's common amongst babies. For some, it means that child needs medication. For some, no, we must move from Formula A to Formula B. For some, it's trapped wind. For some, that mother, she's always eating yams. You know, she's eating fruits, eggs, soy, everything that nursing mother should not eat. That mother is eating it. That's why the child is crying. For some, it's because the mothers switch their breast frequently. So there's fore milk oversupply and not enough hind milk, and therefore the goodness of milk. Now, there was a local study that was done where they looked at local practices of infantile colic, the management and the health outcomes in children. It was a scoping review by Odetola and Abiona from Ondo State. And they actually reported that mothers did a lot and had a lot of different meanings to what colic means. We'll explore some of this as we go along. So generally, we are Nigerians. What do we do when our babies are crying a lot? Although the majority of mothers do not attribute colic to any disease, they were actually willing to use herbal concoctions to treat abdominal colic, as no caregiver is comfortable watching a child in pain and discomfort. Because many of them said when they went to the hospital, the doctor just told them they should be patient, that the cry will stop. But no mother wants to do that, just wait until the crying stops. So they tried many things. And these were some of the findings from the study that I mentioned earlier. The use of native concoctions for infants with colic may be viewed as a common practice among mothers of different cultures and tribes in Nigeria, but the type of the herbal medicine used may likely differ. For instance, Ororo Ogiri was the most used herbal medicine in a particular study reported by Oshikoya and Sembanjo. I still have not been able to find out what is Ororo Ogiri. So if somebody knows, I'll be happy to get more enlightened what it actually contains. But we learned that it is derived from petrified cuckoo Meropsis mani, which are melon seeds, and is used as a local food seasoning among the Yoruba tribe in Nigeria. When dissolved in water and taken by adults, it is said to relieve indigestion by causing excessive flatulence. Its use in the treatment of infantile colic was based on the hypothesis that it removes the excess intraliminal gas in the infant by causing flatulence. So that's what some people think. There's a lot of wind. Use any herbal medication that get the winds out. What else do Nigerians do? The majority of mothers in that study, about 87.7%, applied various substances or medications for colic, which range from paracetamol, 33.1%, Bomoro, in 16.2%, teething powder, salt water, Buscopan, and gripe water. Mothers usually attribute symptoms of most childhood illnesses to abdominal colic. This may have led to unnecessary and sometimes harmful management. The study by Oshikoya and Sembanjo et al. Revealed various herbal substances were used to manage babies with this condition, of which 48% were using, as we said, Ororo Ogiri. Nospamin was also used, as well as gripe water. However, the efficacy of these herbal drugs is yet to be evaluated. So, there are certain treatments that are being given to infants with colic. To recommend or not to recommend. There's insufficient good quality evidence for their use. Simethicone is something that we as doctors usually prescribe, such as Infacol and Dentinox. This is what they contain. They contain simethicone. And how it works is that it is said to break down the big bubbles of air into smaller bubbles so that the baby can easily pass it out. Okay. However, 3 randomized controlled trials showed that it's no better than placebo. I'm sure this is a surprise to us because many of us still prescribe Infacol or Dentinox, as it is advertised widely that it is good for colics. Another RCT showed that protease pump inhibitors are also have no better effect than placebo, so they're also not useful. Herbal supplements, peppermint, chamomile, lemon balm, all of them have been tried. Sucrose solutions in the evenings, gripe water. Gripe water is a very popular one. It actually contains dill seed, oil of bicarbonate of soda, and it is often used by mothers for pain relief. Most mothers use gripe water. I used it on all my children. Whether it worked or not, I do not know. But we all use it, and I'm sure many mothers are smiling as I'm saying this. Okay, but of recent, probably the trend now is towards Infantile and Dentinox and less of gripe water. But there's no evidence that these things work. People just do these things to have something to do. Additionally, even manipulative strategies have been tried just to get rid of that crying. Spinal manipulation, cranial osteopathy, massage, and even acupuncture, just to stop a child from crying. Okay, even bottles, special bottles have been designed, vented feeding bottles, so that the air would escape from the feeding bottle. I'm sure we recognize all these medications: Bomoro, Infacol, Dentinox, gripe water, Colic. Okay, all of them are things that are used, but there's no evidence that any of them is better than placebo. So how do we manage infantile colic when we are told that all these things are not expected to really work? Once a pathology has been ruled out, and the pathology is only seen in about 5% of infants, so that means 95% of babies that actually have colic do not have an underlying illness. Okay, so what we need to do is to reassure the parents and carers that it is a very common problem and it will resolve by around 4 to 6 months of age. However, not just that, we have to advise on strategies that may help to soothe a crying infant, such as holding the baby through the crying episode, gentle motion, such as pushing the pram or rocking the crib, okay, or creating what they call white noise, such as putting on a vacuum cleaner or a hair dryer. It's just something to distract the baby, okay, or bathing the baby in warm water, and ensuring an optimal weaning technique is used during and after feeds if needed. If the mother is breastfeeding, we must encourage her to continue and address breastfeeding problems if identified. We must also encourage the parents and carers to look after their own well-being by asking family and friends for support. It is very overwhelming. You would break down if you don't have support. By the time the baby cries day 1, day 2, by day 3, you don't know yourself again. You need help. So we need to be free to ask for support. We should also encourage such mothers to meet with other parents or carers with babies of the same age to share experiences and access peer support. The mother must be told to rest when the baby finally gets some sleep, okay? And she should put the baby in a safe place, such as a cot, if they feel unable to cope with the crying for a few minutes, just to allow some time out so that she also gathers herself. Now, how about diets and colic? Now, it's been postulated that maternal diet modification, if breastfeeding or changing the infant milk preparation, can help. So some things may work for one baby and may not work for the other baby. One baby may have problems with the feeding, either breastfeeding or formula feeding, or maybe may have excess wind, or may have other causes that would make the child to cry. And so some strategies may work for one baby, but may not work for the other, okay? Some babies may have lactose intolerance. And if you give a medication that would help with lactose intolerance, that baby may respond, but another baby may not, okay? So we must bear that in mind. A randomized controlled trial showed significant reductions in colic symptoms among breastfed infants whose mothers followed a low allergen diet. But this can only work in babies that have allergies, okay? Infants whose mothers excluded cow's milk, eggs, peanuts, tree nuts, wheat, soy, and fish from their diet cried 137 minutes less per day, compared to 51 minutes less per day in the control group. Another systematic review of 6 studies reported the effectiveness of low allergen diets in reducing colics. So that is probably something one could consider, especially if there's a history of atopy in the family, and especially if the mother reacts to some food. Parents of formula-fed infants with colic often consider switching formulas to comforters or whatever comfort-providing formulas. Now, a systematic review of 13 studies found a statistically significant decrease in crying time amongst infants who switched to partially hydrolyzed or extensively hydrolyzed or completely hydrolyzed formulas. These studies suggest that a 2-week trial of a different formula may be considered for infants with colics. Now, medications. What are the roles of medications in infantile colic? The current trend, and probably one of the most exciting recent findings, is the role of probiotic supplements, especially Lactobacillus reuteri, the strain DSM-17938. It has been found to reduce colic symptoms in 4 out of 5 clinical trials. Now, that is quite encouraging. In 2 recent meta-analyses and 1 systematic review found that administration of 5 drops of L-Reuteri per day significantly decreased colic in infants who are breastfed by an average of 61 minutes less crying time per day at 21 days of life. 1 trial found a significant increase in crying or fussing in bottle-fed babies who received L-Reuteri. Based on these results, L-Reuteri may be considered as a treatment option for breastfed infants, but cannot be recommended for formula-fed infants. This is another study that showed up in complementary therapies in medicine, which showed the evidence of Lactobacillus reuteri to reduce colics in breastfed babies. It was a systematic review and a meta-analysis. The conclusion was that Lactobacillus reuteri drops and suspension is effective in reducing crying time in babies with colics. There's another study published in Pediatrics, the journal Paediatrics, also looking at another meta-analysis, also looking at Lactobacillus reuteri. Now, the context of that study was that Lactobacillus reuteri DSM-17938 has shown promise in managing colic, but there's conflicting evidence as to whether it is truly effective. So they set out to, through an individual participant data meta-analysis, they sought to definitely determine the effectiveness of reducing crying or fussing time in infants with colics that I have used L-Reuteri, especially by varying feeding types. They searched online databases, PubMed, Medline, Embase, and all the databases, and they selected double-blinded randomized controlled trials that were published by June 2017. So this is fairly recent, versus a placebo delivered orally to infants with colics. And, oops, sorry. Okay, so the study selection was that there were double-blinded randomized controlled trials published by June 2017. And these studies delivered orally to infants with colics, DSM-17396 L-Reuteri, and they looked at the first less or first more, and the outcome duration was 21 days, okay? They collected individual participant raw data from the included studies and modeled them to multi-level generalized linear mixed effect regression models. And the result was that they found 4 double-blinded trials, including 345 infants with colic, 174 were on the probiotic, while 171 were on placebo. And the probiotic group actually averaged less crying time or fussing time than the placebo group at all time points, and reduced crying by about 21 minutes. Sorry, think my slides are a little mixed up around here. But anyway, the conclusion was that L-Luteri is effective and can be recommended for breastfed infants with colic. Its role in formula-fed infants with colic needs further research. Okay, so they found that it reduced crying time. It did not stop the crying, but what it did was that it reduced the crying time significantly by as much as 61 minutes. So I got curious. I said, okay, so this L-Luteri, how does it come? How does that help me as a clinician? Does it come in natural foods that babies less than 3 months can eat, or does it come as medications? Okay, so these are some of the products that I found online. And they are said to be helpful. Now, when does a mother seek help? Okay, a mother must seek help when the mother or the carer feels unable to cope with the infant's symptoms despite reassurance and advice. If the infant is not thriving or the symptoms are not starting to improve by the age of 4 months, okay, or if there's a suspect for symptoms which cannot be managed in primary care. Now, what are some of the complications of infantile colic? Of course, there's parental and carer stress, anxiety and depression. There's parental sleep deprivation. There's family tension. There's parent-infant attachment difficulties. There could be premature cessation of breastfeeding or premature weaning onto solid foods. Okay, and there's also an increased risk of child maltreatment. So what's the prognosis? Infantile colic, we know, usually improves by the age of 3 to 4 months of age and most often resolves before the age of 6 months. There's conflicting evidence from small studies on whether infants with colic are at increased risk of developing psychological, behavioral, or medical problems, such as allergic or functional gastrointestinal disorders in later life. There's insufficient evidence to discuss that. I'm so happy amongst us this afternoon. We have very senior and very experienced pediatricians, gastroenterologists who have had years and decades of experience with this disease, so-called normal disease, okay, that has been an enigma to many pediatricians. So in conclusion, infantile colic is common and affects newborns up to the age of 4 months. It is, however, a self-limiting condition, but the stress associated with this condition causes parents or caregivers to try various forms of treatments, ranging from pharmacological to non-pharmacological methods. These treatments have all had one effect on one colicky baby or the other, and no effect on another colicky infant. Okay, the role of diet, local or herbal treatments, probiotics are all being studied and have been found useful to various degrees in different children. More studies are still needed to understand this disorder, the cause, and the standardized clinical trials to be done to determine the best treatment modality. Thank you so much for your attention. And I look forward to a robust discussion from our elders with significant experience in managing this disorder. Thank you.
Thank you very much, Dr. Mukhtar, for that enlightening presentation. I'm sure we have all been reminded about infantile colic. We have been reminded about the concepts in terms of etiology, in terms of treatment, in terms of the local studies that have been done on this particular topic. I would just like to do a brief summary of what Dr. Mukhtar enlightened us about. She actually started with an illustrative case report and then gave us our own personal experience, which was quite interesting. So we could learn that even pediatricians have problems dealing with infantile colic. It's not just doctors that I have problem with dealing with colic. It's something we all have experienced, and I'm sure we all have stories to tell about infantile colic. She went on to talk about the definition, starting with the Westall et al. Definition of the rule of threes, which says this baby will have inconsolable crying 3 hours a day, up to at least 3 times a week and over a 3-month period. Thereafter, she also mentions the more current definition by Hyman et al., which also added the fact that these children would not have any faltering in their growth. So they still continue to grow normally despite these episodes of paroxysms of crying. Etiology, she mentioned the fact that it's not really known, but there are so many theories that have been postulated concerning infantile colic, and it ranges from abnormal GI motility, inadequate amounts of lactobacilli, and other psychosocial factors, overstimulation of the infants. All these have been proposed as the possible etiology for this condition. Global prevalence, she mentioned 20%, but it varies from different studies and in different meta-analysis and systematic reviews. But the important thing to note is that this excessive inconsolable crying starts usually in the first weeks of life, usually gets better by 3 to 4 months of age and resolves at about 6 months of age. She went on to talk about the relevant history taking and examination. And another point to take home is the absence of red flags. Red flags are very important features we always look for in the GI. When you see a patient that is having maybe bleeding paparectum, losing weight, having an abdominal mass and all that, we won't say this is just infantile colic. We have to rule out any other pathology in that patient. And she also talked to us about the different differential diagnoses, pathological causes like intussusception, volvulus, and things that would just generally make the baby to be uncomfortable. So we should rule out all this before we conclude that this baby actually has infantile cholestasis. Tight clothing, if the baby has soiled the nappy, if the baby has evidence of cow's milk allergy. She also talks about other differentials like infantile spasms, indigestion, and so on and so forth. She mentioned the myths about colic. In our environment, people always have their own concepts about the etiology of colic, and she went into that. She now mentioned the local study done by several workers, especially the one by Oshikoya and Shebanjo, who highlighted different solutions that several mothers have given to patients with colics. And she talked about the Ororo Giri, and somebody has tried to define it for us in the chat. It's something from melon seed. And then other people have used paracetamol, Bemero, thistle powder. She mentioned gripe water, which she herself has tried in the past. So gripe water is something we really need to talk about, because a lot of mothers use gripe water for colics and even other problems, But many of these did not actually have did not produce any good effect on the babies. So she talks about the management of colics, other medications that had been tried, simethicone, PPIs, herbal preparations, manipulative strategies, but all these, there's really no conclusive evidence that they all work. So out of all the treatments that she mentioned, it looked like, at least in breastfed babies, the use of the probiotic Lactobacillus reuteri has been found to be quite useful, especially for breastfed babies. But for formula-fed babies, it may be advised that they go on hydrolyzed formula. And if there's any family history or any history suggestive of atopy, then we can ask the mother to be on low allergenic diet, and then hydrolyzed formula may be very useful. So we want to thank you, Dr. Mokhtar. And now we will go into a session of question and answers. Please, if you have any questions, you can drop them in the chat for us. And you can also show with our electronic hands if we have any comments or interesting questions, any burning issues that you would like the speaker to address. Dr. Eletu, can I start with the questions in the chat box before we take the...
Yes, please. Go ahead.
Electronic hands. Okay, sir. We have a question. Well, we have some comments actually. As part of the differentials, Dr. Yeyemi says neonatal abstinence syndrome can also be a differential for infantile colic. There's a question that says, can presence of fever and vomiting be an exclusion criteria for infantile colic? Dr. Muritala wants to know whether the presence of fever and or vomiting can be an exclusion criteria for infantile colic.
Well, thank you very much, Dr. Muritala. Usually, as we said, infantile colic is a diagnosis of exclusion. You have to make sure that there's no underlying pathology before you conclude that it's just infantile colic. So once you have fever and vomiting as the presenting signs before the excessive crying, then obviously you should look for an underlying pathology. Mind you though, a baby that cries for 2 hours will get warm and can vomit, okay? So you have to differentiate the two. Thank you.
Okay, thank you very much, ma'am. Professor Bunide here wants to know, has there been any study or preview establishing any relation or lack of it between colic and later pathologies in childhood, for example, epilepsy? Has there been any study establishing any relationship between colics and other pathologies later in life?
Yes, sir. I think that was mentioned on the last slide, but one, that there's no concluding evidence that there's a relationship between colics and some long-term illnesses in these babies, even though some studies have reported association with the psychosocial and behavioral issues, but there's no good quality of evidence to prove that it is so. So I don't think there's anything tentative, at least I have come across.
Thank you, ma'am. Dr. Ajayi-Obe, Dr. Dayo Ajayi-Obe, I can see your hand up. Can you unmute and ask your questions or make your comments, please? Dr. Dayo Ajayi-Obe. Is Dr. Ajayi-Obe there? Your hand is up. Can you unmute? Okay, maybe he's not there anymore. Our Mama Professor Grange-ma, please, can you unmute and ask your question, ma?
Thank you very much. As usual, I have really enjoyed this wonderful presentation by MARIYA, Dr. MUKHTAR-YOLA. Of course, I know her very well. We know each other very well. And I was disappointed that you didn't go into gastroenterology, but now I am consoled that you are in it by another route. So that was a really good presentation. Thank you.
Thank you very
you started with your personal experience.
Yes,
I think that was really good. And I want to say that that was the only thing that we had in those days, personal experience. And we ran around trying to look for solutions. And, you know, solutions were usually not effective, but we convinced ourselves that we were doing something. I want to mention that one thing that I found from personal experience that was somewhat effective, which you did not emphasize, was the placing the baby's tummy on your lap or on your tummy and letting her have warmth from there. Sometimes we added water bottle that has been wrapped well so that it doesn't cause any burns, and put it there, put it on the tummy. And you know, within minutes, this baby would start series of flatulence, which would now relieve the baby for an hour or two, and then you have to do it again. That was how we got by in those days. And that has linked me up to my personal experience now, 13 years ago, with my grandchildren. That was what I also tried. And it seemed to work, because by that time we had not gotten the the benefit of this special probiotic to use, etc. And so we were still using our basic experiences. Now, you also talked about the pattern and the fact that the most important thing is to exclude dangerous problems, trauma, or whatever. I think that is a very important thing for pediatricians to know. Once you exclude that, then you are dealing with just infantile colic, and the rest is up to you how you handle it. And luckily for us, we now have this new method of handling it. I just want to sound a note of caution with using either local medicines or other medicines, etc., because these are posing threats on the issue of exclusive breastfeeding. In those days, of course, there was no exclusive breastfeeding, so we were, not threatened by them. But you need to be on the lookout with the use of medications and ensure that it doesn't go on to loss of exclusive breastfeeding. Finally, relating colic to psychosocial behavior, it's very tempting to do so. And I have been watching my dizygotic twins from birth till now. They are now 13. And I'm seeing differences in psychosocial behavior. and, one of them, who is the girl, is certainly more challenging. And she had colic. She had terrible colic. So I don't know. I'm just, this is by way of just mentioning that there could be a relationship, but it's a very difficult research to set up, and I would suggest that they actually do it on twins, twins, who one may have shown colic and the other one didn't show colic, etc. And we may get some answers, some solutions to that. But I'm happy to say that her psychosocial behavior is not beyond management. So thank you very much, Maria.
Thank you so much, Ma. It's always a pleasure to listen to you. By the way, just to mention that I was privileged to serve as a registrar under Professor Adenike Grange after she returned from UNICEF. And she was a goal-getter. She drove us well. So thank you very much, Ma, for all that you have done. We appreciate you every day, and we continue to pray for you. The comments you have made are all very well noted, Ma. That's all I can say. Thank you, Ma.
Thank you very much, Prof. Ma. Thank you for the contributions. Dr. Ajayobe, please, can you unmute and ask your question?
It seems to be having some problem with unmuting.
Okay, so we'll go on. Okay. Maybe you can, Dr. Ajayobe, you can please type your question in the chat box if you are still having problems unmuting. Dr. Jimo, please, can you ask your question? Can you unmute and ask your question? Dr. Jimo.
Thank you very much. My name is Dr. Jimo from Bingham University Teaching Hospital. Thank you very much, Ma, for the presentation. Infantile colic, when I saw it, I was really excited because, like I said, it's something that we can all relate with as mothers who are pediatricians, and we can also relate with it in terms of seeing our patients, the mothers when they come and all that. So just like what Prof just said now, that was one of the things I wanted to share, that I wanted to ask. The role of placing the tummy on the mother's, not just her chest, on mother's breast. That's one thing personally that I did, because I had also children who had infantile colic. And then apart from that, then a gentle massage on the back. Then another thing that I noticed that works, and I've recommended it for patients, and it actually worked for them too, was that if the child is overclothed, overdressed, to loosen up the dress.
Okay, thank you, Dr.
So before it worked. Then the other thing that I want to raise is that, like Ma, you've said that, you know, those who use gripe water and all that. In fact, I remember that gripe water was probably one of the things that mothers always have in their box for their babies and all that, using gripe water, especially in the advent of all these different kind of chemicals that we're seeing, different things mothers are giving and all that. So I'm wondering if, as pediatricians, we probably need to make a statement to discourage the use of all such things completely, knowing that we do not have complete control over the chemicals that are used to make these products now. Because mothers may think that they're solving the problem of infantile colic, but now the children end up with having acute kidney injury and then deaths on our hands. So thank you very much, man. It's a very beautiful presentation. I'm very happy that, you know, that this was so well discussed and presented. Thank you, ma'am.
Thank you so much, Dr. Jimo, for your inputs. As we all know, there are various steps and strategies to winding techniques, as in trying to bring up the wind in a newborn baby. And what Madame had described is well recognized. And the one we always advise, put the baby on your shoulder, rub the back, you know, until the baby belches, put on the laps, you know, there's so massage, there's so many ways, you know, to do it. So that is well noted. And it works for those with excess wind. It may not work for those that do not have winds. So we must have under our kitty a little advice for every condition. Now, the truth is, if we're to ask ourselves the truth, let's say in the last 1 month, those of us that are sitting in the clinic and a mother rushes into us with infantile colic and the child is crying nonstop and the mother is going crazy, you know, and you've advised her, you know, that she should be patient and all that. You've advised against all these things. And then the mother says, "Doctor, I need something. What can I use?" If you don't even prescribe it, your neighbor would. You know, the neighbor would do it, or the pharmacist would do it. So it's not, I don't think doctors prescribe gripe water. I don't think doctors prescribe Bomoro. Okay, doctors may prescribe Infacol and Dentinox, probably because they're Oyinbo drugs that they've told us that they break down, they help with wind excretion and all that. So a lot of the medications that are taken are actually not prescription from doctors. So we can't tell, we should, and I agree with you, we should be able to advocate and tell people that these medications could be more harmful than useful, okay? But what we have found is whether you prescribe or not, the grandmother would do so, or the neighbor would do so, or the mother would go to the pharmacist and buy it. So we need to educate. We need constant education against the use of herbal medications, against the use of drugs that we know have no value, really. So we need to constantly inform the parents about all this. So absolutely, your point is well taken. Thank you.
Thank you, Dr. Mukhtar. Dr. Fajolu, please, can you unmute and ask your question?
Thank you, Dr. Adeni, and thank you, Dr. Mukhtar, for the excellent presentation. Before we started, I referred to her as Madam Speaker, and Dr. Molaji Lawal said that a big amen to that. So maybe she's going to be the next speaker. Okay, thank you very much. Yes, I guess I was just a very lucky mother. I can't remember any of my children having colic, but I guess maybe I preempted it and did more of the lying them on their tummy for a long time. I mean, most of the time. So even when they started crying, before, I didn't wait until 3 hours or any 3 before I put them on their tummy, and that seemed to help with my own baby. So I didn't really have this experience. And I tend to prescribe that for majority of the patients that come to me. But I want to make a comment on the studies on the probiotics and being effective in breastfed babies. I'm thinking that is it possible that there is synergistic effects with these probiotics and the naturally occurring probiotics in breast milk, and that is why we're not having any effect on babies who are formula fed who do not have probiotics. So were the studies done on babies who are on formula milk, which have probiotics in them already, you know, because now these babies already have a naturally occurring probiotic in breast milk, and you're giving another probiotic, and this may be the reason why we're having that effect and not the other babies who are on formula not having effect, not having any benefit from it. I'm just thinking, is that the reason? Could that be a reason why? And if there was any information on what type of formula these other babies were on. Thank you, and well done.
Thank you so much, my dear friend, Dr. Fajolu, for that brilliant search into the reason behind the response. Now, breast milk is very blessed with a lot of probiotics, and L-Luteri is said to work best in babies that are breastfed by reducing the crying time by up to about 61 minutes. Now, I do not know the studies, or rather the independent review did not really define which formulas were used. But since these studies were done in the last 5 years, one would assume that some of the formulas probably would contain some probiotics. I don't think I can conclude on something that was not concluded in the studies, but that was all that the study reported. It could be an additive effect, or it could be that it has no effect on babies that are formula fed. It's a new field, it's a green field for future research, and I'm sure a lot of people are now looking into it, probably using specifics to further understand this enigma. So I don't have an answer for you, but it could be, and it may not be. I don't know. Thank you.
Thank you, Mariya.
Okay, thank you, Dr. Mukhtar. We still have some other questions in the chat box. So I'll go back to the chat box now and read out some of those questions. Dr. Sanusi wants to know, a lot of babies with colic are also diagnosed with gastroesophageal reflux. How common is this in your experience at National Hospital? Do you use Prilosec for treatment if gastroesophageal reflux is suspected? So he's talking about the overlap between gastroesophageal reflux and colic. What is your experience at the National Hospital, and do you use pre-USEC for treatment?
Okay, yeah, thank you very much for that important information. Actually, I would say that we tend to underdiagnose gastroesophageal reflux in babies. We just attribute it to the babies are burping, they're bringing up a lot of secretions, and it will stop, it will stop, it will stop. But there are a lot of babies that are actually refluxing, and they get help, and they do better with a little help. I don't have much experience with the drug that you mentioned, but I do know that we've had a couple of babies that we had to give excuse me, the name just escaped me now, but it will come back in a minute. And they responded perfectly for those that we felt had reflux, but not all of them that had, of course, not many of them that had colic had reflux. But I don't have much experience with the products that you're mentioning.
Okay.
So
I think the
Prisonec should tell us.
Prisonec is omeprazole, actually. It's a brand name.
It's omeprazole, yeah. So in fact, that's the drug I was going to talk about. It's omeprazole. If you use it at 1 milligram per kg daily for the babies for a period of 1 to 2 weeks, those that really have a gastroesophageal reflux, you'd see a response in them.
Yes, I think I agree with Dr. Mokhtar, so that if there's concomitant gastroesophageal reflux with the use of a PPI, there will be some significant improvements in the symptoms. So if you have a strong index of suspicion that there is also GERD, then we can also prescribe a PPI. Okay, Dr. Uma says, I used to recommend gripe water to mothers, but I stopped doing that when I spared the effort to read with hand bends the over 25 chemical names listed as part of the ingredients in a brand, recalling that there's still no research evidence on the usefulness of these products. Would it be advisable to still recommend use of such products in a country where many products find their way across the counter in markets, not only in pharmacies? So Dr. Uma is asking about the use of gripe water in summary.
Yeah, pediatricians would not recommend it. We shouldn't, and we should discourage it because it doesn't work. And we don't know what we're putting into the babies, so we shouldn't. We should discourage its use.
Thank you. Other questions? Dr. Salako says, good afternoon, ma. Is the L-Reuteri suspension available?
I've been raising my hand.
Gripe water and the likes.
I've been raising my hand.
Okay, sir. Oh, sorry, sir. Dr. Ajay Fuja, sir. Okay, sir. Please go ahead with your question. We'll go back to the chat.
Congratulations, Dr. Mokhtar. Well done. But the most important thing in 3 months colic, as we call it, or infantile colic, is the way the mother wins the child. I mean, you were in Sheffield, and we are told on no counted times that when they feed out midway, you win them. And then when they finish feeding, you win them. If you don't break the winding, then of course they have this air bubble over there, and then there is no place for gripe water, as Dr. Green said, and there is the winning. The mothers really don't know what to do. I used to do a lot of this in Massey Street, and then the women used to laugh at me. So they're saying that to imagine that a man is teaching them how to win the child. They have to win in the middle of the feed and at the end of it. If they win it, they don't need any gripe water, no medicine, and no medicine at all. And all these 60-something years I've done it. I've never given anybody any medicine. Well done, Dr. Mokhtar. And thank you for the talk. Thank you.
Thank you very much, sir. Words from elder. That's a wealth of experience, sir. From today, I'll start recommending mid-feeding winding. and we'll see how it works. I'm sure it will not fail us from what you have said, sir. We'll try that, sir. Thank you very much. It's always a pleasure to see you, sir, and thank you for joining us. We appreciate it.
Dr. Jane Freya, sir, for the contribution. We appreciate you, sir. So back to Dr. Salako's question about the availability of Lactobacillus reuteri. Is it readily available, especially in suspension? Can it be substituted for gripe water and the likes? A lot of companies are coming up with so many formula with L reuteri in the name of reducing colic in babies. What's your take on this?
Well, thank you so much for that question. The truth is that L reuteri is it's a probiotic that is present in many natural foods. It is present in yogurts. It is present in even some vegetable fibers, that eventually release the organism. It is present in many natural things that we eat, but we are talking about the babies that are less than 4 months. So these are not babies that can eat these natural foods, okay? So that's why we're talking about how do we now, if it is as effective as those studies reported. I have no personal experience with it, but looking at the literature and the science behind what is reported, if it is going to reduce crying time by as much as the time that has been reported, then it is something to consider. Definitely, it is available abroad. I know that it is very much available, and in high-end pharmacies in Nigeria, probably it might also be available. I don't know. I have no interest to declare here. I'm just talking about the science as of this moment.
Okay, thank you, Dr. Mukhtar. I think I'll take the last question now, and because we are running out of time. I think Dr. Iletu says, how common is hypocalcemia in babies administered gripe water? How common is hypocalcemia in babies administered gripe water?
Okay, I don't know. But it's an interesting question. I would look it up. But if you have experiences, we'd be happy to hear.
Okay, thank you very much. I mean, I remember during my neonatology postings, we saw quite a few children who had gripe water and had seizures. And at the end of the day, we found out that the main cause of the seizure was hypocalcemia. And Professor Iroa will always tell us when we're taking a history, when you see such children, find out if the mothers have given gripe water before they brought the children into the hospital. So that's why I was asking whether others have the same experience. Thank you very much.
My neonatology posting is ongoing. Thank you, sir.
I was saying that was the last question, but I saw something on news farming, and I think we need to address this before we round up. There's a question here about, please, what is known about nospamin in the treatment of colics? What is known about nospamin in the treatment of colics?
Well, it's just like Infantile. It's an antispasmodic. Okay, so the best probably it can do is to cause some relaxation of the bowel. So it's only babies that have spasms that will respond to it. Okay, so it may work for some and may not work for others. There's no evidence that it really helps with colics.
But we're not supposed to be recommending it, Dr.
No, we can't. We can't because there's no evidence. There's no evidence.
Thank you very much for all the interesting questions. We've had a fruitful deliberation. Dr. Dorothy, your comments is noted about the issue of adding Colic if the baby is failing to thrive after we've given all our recommendations or treatments to a child with colic. So if a child is failing to thrive and you suspect reflux disease, you can also add a PPI to the management. At this point, I would like to hand over to Dr. Iletu for the closing remarks. Thank you, everybody.
Thank you very much, Dr. Adeni and Mukhtar. Well, I'm so happy you stepped in at the last minute. And like the chairman said before we started, you rescued us. And I'm sure you know we'll come back to you again at some point. Also, Dr. Adeni, this is just to sound a note of warning that very soon I'll be knocking on your door for your presentation. Before I round up, I'd like the president to say a few words. Dr. Mbolaji Lawal, are you online, sir?
Yeah, okay, yes, let me put on my video. Yeah, okay, so thank you very much, Dr. Eletu. Sorry, I went off temporarily at the beginning. I was trying to change my Wi-Fi source. So yes, you have re-echoed what I wanted to say then, is to thank Dr. MUKHTAR-YOLA so much for accepting to do this presentation as last minute, when it appeared as if we may not have somebody to present. And she has done an excellent job of it, as you can all testify to. And you know, to also mention that Dr. MUKHTAR-YOLA has been very active in this group and is always offering herself to serve. You know, I recall that he served the Paediatric Association of Nigeria as treasurer for many years, and he's serving this organization as well. And I can say that he's a very, very important member of the executive committee. So thank you, Dr. MUKHTAR-YOLA, for your services to this group and for this lecture in particular. I'm not surprised at the enthusiasm for today's meeting and the quality of the comments, because it's a very interesting topic. And you see, our women all have personal experiences. I did not hear any man sharing personal experience. So I want to encourage the younger men who are still in the business to take more active, to play more active role in looking after these babies when they are small, so that they can also share some personal experiences of what can be done to these babies at future meetings. So thank you very much. Over to you, Dr. Eletu.
Thank you very much, sir. Well, I'm sure some of the men obviously have some experience, but they're just shy to share. And like we rightly said jokingly before the meeting started, I want to thank Madam Speaker again for.
Oh, come on.
Said, it's very prophetic, so we won't be surprised in a few years. Well, you may say no now, but you never know. So thank you very much, Maria. And I want to thank everybody for creating time to be with us today. And just to tell Mr. President, sir, that we had a very good trouble, if I may use that word, like the Americans would say, because we had over 100 people joining in. And at some point we had to create another YouTube forum, which we shared, and for other people. So some people joined via YouTube rather than Zoom. So we may have to look at other ways to expand the numbers.
Okay.
So Maria, I think you broke the record. So,
yeah, that is noted.
Okay,
you did a good advertisement, sir. The credit goes to you.
Thank you. So we look forward to seeing everybody next month on the 24th of November, which will be the next meeting. And thank you, and have a wonderful morning and wonderful afternoon stroke evening, wherever we are. Thank you very much, sir. Thank you.
Yeah. Thank you. Thank you all. Bye-bye.